another distinguished person. She's an anesthesiologist by profession, but she has passion in pain and palliative care medicine. She's a associate professor at the MNJ Institute of Oncology and Regional Cancer Center in Hyderabad, India. She's one of the persons who trained these doctors and nurses. And this is none other than Dr. Gayathri Palat. Welcome, Dr. Gayathri Palat. You have 10 minutes for your presentation.
Thank you very much. While I do the screen sharing, I just want to congratulate the entire team. I've been part of this journey. Part of it, I've been together with the team, and they've come a long way. And they're doing such a wonderful program in northern part of Sri Lanka. And really, I want to congratulate all of you, congratulate the leadership and the people who are so much involved in palliative care. And I was asked to speak a little bit about what's happening in India. We are just the neighbors, so how we are doing in India, and the kind of program which I do in my place. I thought that's something which I will share with you, all of you, today evening. I think a lot of similarities between what's happening in Sri Lanka and what's happening in India. While we're still struggling with a lot of these communicable problems, there's a huge burden of non-communicable disease becoming the leading cause of death. And that's the reason that why there's so much of discussion around palliative care. I saw one chat discussion going on, which was happening about what's the percentage of cancer and how much non-cancer. And it's very true that the big chunk of palliative care need is for the non-cancer population. Very much similar like in Sri Lanka. We see our cancer burden is huge. We see around 1 million cancer cases every year, and 70% of them, the rich or poor, they don't get cured. By the time they seek any medical advice, they're in advanced stage and they will require palliative care. So that is the picture which we have in India. It's very similar in most of this region of the world. We are talking about palliative care, we're talking about dying. So how do people die in India? When we talk about patients with incurable diseases, as one of my organization members says, they don't belong anywhere. They're simply told nothing more can be done, take her home, take the patient home. They're outside the gamut of regular healthcare system because that system is not meant for them. What happens to them then? They go around searching for some care from one hospital to another hospital, or sometimes to acquire some non-medical support, and finally spend a lot of money and they become more poor. And finally they die in pain and suffering. That is a picture, most of us, which we undergo. With this background, how much palliative care do we have in India? Now, this is a global mapping of palliative care. What is the kind of palliative care development happening in different countries across the globe? If you look at it, where you see the dark blue color is a place like how you see where Jonathan, Meera, where you all are working. It's very well integrated into the healthcare system. But a country like India or Sri Lanka, it's still very patchy. Just not there. Somewhere it's happening, somewhere it's not happening. It is not, we are inching towards integration into healthcare system, but it's still very patchy. In spite of all that, in India, we have achieved some milestones which has really helped us to move forward in the area of palliative care. The Medical Council of India recognizes palliative medicine as a broad specialty now, and we have MD in palliative medicine, which is a postgraduate training program. Unlike many other national programs, health national programs like tuberculosis control program, malaria control program, now we have a national program for palliative care, and there's a separate budget allocation for palliative care. And they encourage palliative care to be developed in districts. They want all the districts to come up, not centralized to one center of excellence. It should be spread across the districts. That is what they aim at, and they have a budget allocation for that. We all know that palliative care needs specialized medicine, especially medications like opioid medication, and it comes in India, it comes under the purview of Narcotic Drug and Psychotropic Substance Act, and it was very strict, so stringent that it was not available for medical use. But recently Government of India relaxed that regulation also, so that it is now more freely available for medical use. So these are some significant milestones. But if you look at this map, it's a very rough map. Just to make a point, it's still somewhere scattered all over India. But if you go to down south, you see cluster of red dots, which is the state of Kerala, where maximum palliative care is happening. And the next state, I can say that it is a state where I work. I'm currently involved with the state of Telangana. More palliative care is happening. State health is a state subject. So each state decides how they want to take forward their health. So that's the reason there's so much of difference if you see each state. I work in state of Telangana, and let's understand a little more about the model which we follow in state of Telangana. And I worked in the capital of Telangana in a cancer institute, which is Tertiary Cancer Center. And this center currently is the nodal cancer center for clinical services, training, research, and advocacy. So this is where they came, Dr. Madhurahan and Gaushigan came for training. And sitting in this cancer hospital for me, it helps me a lot to work with the government, and I could bring many changes with the government related to palliative care policy. In fact, today in our health insurance system, state-sponsored health insurance system, we have included palliative care, which is very unusual thing. We have all formulation of opioids available in a center like morphine, fentanyl, methadone. So we play a very important role in setting an example for the rest of the state and the country. While working in cancer hospital, we have realized that most of our patients, when they come, initially they all come for treatment and then they're referred to palliative care. But after some time, they stop coming because they're too sick to travel and they don't come to the hospital. So if you're talking about end-of-life care, it cannot happen in a very centrally located hospital. That's the reason very soon we realized that we have to have an outreach program if you really want to take care of those patients. A part of very unique program of MNJ Cancer Hospital is what we very proudly we can say we have a very unique pediatric palliative care program. Incidentally, yesterday only we got this news that the Royal College of Pediatrics UK, they have endorsed the program which we offer here for pediatric palliative care fellowship. So we conduct a lot of training program around pediatric palliative care. Incidentally, 10% of our population are children living with life-limiting conditions. In the community, we take help of one NGO called Pain Relief and Palliative Care Society, and through that NGO, we provide care in the community. We make visits like how in the beginning the case discussion was done. We do a similar program. We reach out to the patients in their homes because that's where they belong, they live. They prefer to have the end-of-life care. So we reach out to them in their homes and take care of them, going into different terrains and providing all possible nursing and medical care to such terminally ill patients. Many of these patients, when they cannot be managed in the home, they're too sick. In the family, if you see this patient, this is all they have as a home. The family, 2 children, she's an old mother. They all live in the small house. On the left side is the kitchen, and this patient has a huge wound with maggots coming out. We cannot manage such patients in the home. And that's a situation when we shift them to our hospice facility. This is a hospice where we look after terminally ill patients, and we have again a separate set of team of doctors, nurses, counselors, and pharmacists. They're all together trying to provide end-of-life care to these patients. So there's a seamless movement of patients between the tertiary hospital, home, and the hospice. Patients move between different programs, and it's all very closely, very nicely interlinked. Seeing the effect of this program, the government of Telangana invited us to help them to establish a district-based palliative care program in the state. And very proudly I can say that now in Telangana, through the National Program for Palliative Care funded by central government, we are reaching out to all the districts. If you see, these are very small community health centers, and the If you see on the right side down, right side, the small tiny little building you see, it's by the side of community health center. They have a hospice, and inside of the hospice is what you see up on our photo. And on the left side is another hospice facility we have, another district hospital. There also they provide inpatient, outpatient and community services and very remote places like how it was described in my initial case study. The community program really helps us to do major awareness in the community. Awareness about palliative care, the need for not to suffer in pain and symptoms if you have, seek our help. Also, it also helps us to do away with a lot of stigma which comes with these kind of life-limiting conditions. The lessons learned, end of it. Like Meera said, palliative care is everybody's business. It's for you and me and for all of us. We need to create a global, compassionate community. Then only we can have that universal access to palliative care for all of us. The lessons which we learned is, as you see, we have a very nice partnership of a government institution, a local NGO and international NGO. We all work together. We bring a international NGO, they come with their own expertise. The society, the NGO brings its own whatever the strengths they have, and the government, of course. When you're sitting in a government hospital, you have your own strengths. So much you can influence the government. And similarly, you need help of, if you see on the right side, we work with various societies like dementia societies, academic of pediatrics, pulmonology society, because if we really want to reach out to those populations, we have to work with them. And similarly, if you see down lower part in yellow highlighted, how the volunteers are so important to help our program. And on the left side, we have corporates and philanthropists who are giving us money, because without money we can't work. So we have to all work together if you really want to improve access to care. With those notes, I finish my presentation. Thank you.
Thank you, Dr. Gayathri, Palat. We are, hoping to send more people to you for training from Sri Lanka. And your presentation, amazed me, the amount of the population in India and the rural part of India. You guys are doing amazing. So as a Indian medical graduate myself, I can feel that. And, thank you so much for today's, presentation and your time. And we are really looking forward to collaborate with your institution for, training of our medical doctors and nurses. Thanks again.
Thank you. It's been my pleasure. Thank you. Privileged to.